Why don't you give us a background of the current antibodies, what their targets are, and how safe and effective they are?
Well, we'll start with what we have. There are 4 monoclonal antibodies that have anti-CGRP effect, 3 of which are FDA approved. The first one that was FDA approved was arenimab. Brand name is Aimovig, and it is different than the other 3 in that it is a purely human monoclonal antibody, and that it is the only one which targets the canonical alpha-CGRP receptor.
Is that religious? Canonical?
And the other 3 target the CGRP ligand itself. They do not target the receptor. The other 3 are humanized or fully humanized, meaning that they are 5 to 10% murine. And whether that has immunologic consequence, we don't know, but most of our neurologic monoclonal antibodies that are used in practice are humanized.
Can I comment?
Please.
The naming organization for antibodies has changed the designation of all antibodies. So for example, an antibody that's 100% human is called UMAB. An antibody that's minimal, mainly human, and a little bit of extra human tissue, a part of it, is called ZUMAB. The way I remember a zoo for an animal. That has been eliminated. The authorities strongly believe that the current distinction between human and humanized is irrelevant, and that any antigenicity of the antibody is due to the specific structure of the FAB fragment that binds to the antigen. That's just happened. So all antibodies in the future will never be indicated as humanized or human, and that designation will exist with prior antibodies.
And just to finish on that, the N in the name of these monoclonal antibodies is for neurologic.
Correct.
So,
and that will disappear too.
And Steve taught me that. The remaining 3, the second one that was approved was fremanezumab, brand name Ajovy. The third was galcanezumab, brand name Emgality. And the fourth, which is not yet FDA approved, but which has been submitted to the FDA as of February of 2019, and which we anticipate next year, is eptinezumab. The first 3, the 3 that are approved, are available for home use with a subcutaneous injection. And we'll go over the doses and how that is done. And the fourth one, when it becomes available, eptinezumab, will be available as a quarterly IV infusion.
Which patients are eligible for antibodies?
You know, I think that now that we have treatments that don't have as many side effects as the oral medications, and we don't have as much of an issue with adherence, because these are self-injected monthly or quarterly injections in the case of Ajovy, I think it's changed the whole dynamic. I would preferentially choose a monoclonal antibody as the starting point.
But you can't.
Well, but in an ideal world where cost had no bearing on our decision, I would feel that these were the ones that had the best safety, best tolerability, and greatest efficacy. So why not use those as a starting point? Why walk through the hoops of medicines that have potential side effects and less efficacy?
Who wants to comment on that?
Oh, you're taking a deep breath as if you
Oh, you
really
want
had
me
something
to?
to say.
All right.
I'll
Well,
piggyback
first of all,
off
I think that we ought to take one step back for a second and point out the other a number of other differentiating features about these. When we talked about onabotulinum toxin A, for example, we were talking about its utility in chronic migraine, patients who had 15 or more headache days per month. These monoclonal antibodies have taught us that migraine is migraine, and that when you take out CGRP, these drugs work equally in patients who have low-frequency episodic migraine, high-frequency episodic migraine, chronic migraine, migraine with aura migraine, without aura migraine, with medication overuse, acute medication overuse, migraine without acute medication overuse. Very remarkable shift that we have such potent treatment for the entire gamut of migraine. So the first response to Steve is, these would work for any migraine patient that we have. then
Who's an adult at the
reality
moment.
then sets in.
An adult at the moment.
And
and
adults,
not
thank
pregnant,
you.
preferably. Yeah.
Thank you, and not pregnant patients. But the reality is that payers are requiring patients to have had a lack of success with certain categories of previous treatment. And as a result of that, the American Headache Society published a white paper in January of 2019, making what I think was quite reasonable recommendations to payers as to what kinds of prerequisites would be present before we could do what we hope the future will bear, which is use it first. And they divided patients into 3 groups. They said if patients had low-frequency episodic migraine but demonstrable disability or impact, those patients should be considered for monoclonal antibodies. If they had high-frequency episodic migraine or chronic migraine, they were only required to have failed 2 previous treatments, and you didn't have to demonstrate disability because we know those patients are disabled or have impact. And in the case of chronic migraine, one of the 2 categories that the patients could fail would be onabotulinum toxin A. So pretty simple.
No. Onabotulinum toxin
For
by
chronic
itself,
migraine.
For chronic migraine, because by definition, to get onabotulinum toxin type A, you had to have failed in your system.
Thank you. Yep.
So the fundamental difference between the 2 episodics and the chronic is in the chronic, it's 2 other or Botox. Whereas in the episodic, the difference between low frequency and high frequency, low frequency, 2 failures plus evidence of disability.
Just to be clear, it's the drug, the treatment that fails, not the patient that fails.
That's right. It's a lack of success.
Thank you, Dr. Bill.
It's really important to make that point.